Welcome, everyone. So today's general goal is to simply enhance your pulmonary functions testing, interpretation, expertise, and your confidence. And whether you work in an outpatient clinic or you simply have just an interest in PFTs and the correct interpretation thereof, today's webinar is for you. So in theory, we've got these learning objectives, and I do have confidence we'll hit all of these today, but hopefully you'll be able to have confidence to interpret a basic spirometry report and also a complete PFT. And we're going to give you something to walk away with as far as knowledge for a lifetime. I'm going to bring you some latest changes. Some of you that have done PFTs for many years, there are some changes to the interpretation methodology in the last couple of years. So I do want to give you a heads up there, and I'm going to emphasize those more than once. We're going to categorize patients, recalling that you cannot absolutely diagnose from a PFT. It's just part of the puzzle. And then we're going to, lastly, and arguably maybe the most important here, is give you some clinical implications based upon what you interpret. Now, for the first portion, we'll move rather quickly so we can dive into the process of interpretation. But my understanding is you'll be provided this slide set with all the references. In addition, I've also provided my email on the last slide, and I'm going to leave time for a few questions at the end, so prepare those if you like. Just a quick disclaimer to start things off. During this presentation, I am going to mention certain drug names, pulmonary function devices, and maybe a company or two, but I'm in no way affiliated with any of these or compensated. In the fine print down here, I would, however, not be opposed to the idea of making medications more affordable for our patients by decreasing the amount of profits and kickbacks to affiliated companies, corporations, and representatives. So let's get into it. It's always helpful to appreciate from where we've come. And as you're aware, technologies are ever changing. And although much in respiratory care hasn't changed all that dramatically in theory, the pulmonary function testing of today looks almost nothing like PFTs of yesteryear. Historically, you have a gentleman by the name of Galen, who was a Greek physician. He was a surgeon, a philosopher, which wasn't everyone back then, right? He observed a boy breathing into a sealed animal bladder with no volume change. He's seeing this from a distance. In other words, what breath or volume in particular was breathed in was breathed back out equally. So this started the whole thought process of measuring the breath. Now, not too much has happened between 100 AD and the 19th century related to pulmonary functions testing. But fast forward about 17 centuries, and we have a gentleman by the name of John Hutchison. Now, he was credited as the inventor of the spirometer, and he published a very famous paper in 1852 about water spirometry, and it changed everything. Incidentally, it is documented that at age 41, he abandoned his wife and kids and moved to Australia. So I guess that just proves that PFT interpretation can drive you crazy after all. That was a joke. Real story, though. So all that aside, the spirogram, as it comes to be known, was not really possible until the so-called kymograph, which means wave rider, came about. And the kymograph, as shown here, actually allowed the spirogram. And it was invented by German physiologist Carl Ludwig in the 1840s, but perfected by the famous John Hutchison. You can see here from the bottom left picture that we've come a long way. Do note, however, the larger picture to the right visually demonstrates the relatively simple concept of blowing into a sealed system. And this happens to show a water seal spirometer. So this is the drum in which the water is sealed off. And then the chamber to the far right here that you see is only part of it. It displaces upward and allows an indication to be recorded on what you see to the left here, that spinning drum or kymograph. And it utilized the old pulley system up at the top here. So the question is, where are we now? Well, we're not just here to talk about PFT history. Let's get into today's subject matter. Now, it's a worthy starting point, right? What is the test? Now, I can assume most all on the call have done the test with patients. Maybe you've experienced the test as a patient, but certainly you've studied it in school or you wouldn't be here. And in its purest form, simple spirometry, as it's known, is just a basic evaluation of a patient's inspiratory and expiratory flows. Now recall that conceptually, actually in a literal sense, mathematically, flow by definition is just volume plotted over time, as you see there, that equation. Spirometry, by the way, is the most common pulmonary functions test. However, it is not the only PFT, right? Now, we will not do a lot of math during today's session. Everybody can breathe a sigh of relief, but it's so important to appreciate this relationship between flow and volume. And we're laying some groundwork here, so we're headed somewhere. What is measured during spirometry is simply how much volume is being moved over a certain time frame. And this renders a literal flow rate, usually in liters per second or liters per minute. Notice volume over time. Before I proceed, just an early commercial here. Since we're talking about simple spirometry or any pulmonary functions test cannot single-handedly allow for a diagnosis. Again, it's just part of the puzzle. For example, hopefully by the end of today's webinar, you can appreciate that based on spirometric results, whether someone has obstruction or not, but you will not be able to glance at a single test and say, for example, yes, this patient definitely has bronchiectasis, or, I see based on these spirometric results, this patient absolutely has emphysema. Now, if you have clinical history, if you have other diagnostic tests or other indicators, you can put it all together and maybe definitively say they have X diagnosis, but not from PFTs alone. And I can't emphasize that enough. And by the way, while we're on spirometry, you can only simply rule in or rule out something such as obstructive disease. For restrictive conditions, you can't really rule in a restriction until you get a complete PFT. So put that in the thinking cap. So let's be clear, a pulmonary function study requires patient cooperation and many times near maximal effort. Think about these older patients, frail patients, those who are undernourished or they just don't feel well or they're on polypharmacy. So there's a plethora of medications their body's having to process. They're not going to feel like you and I. They may not be able to perform what you ask them to, but it's still our goal that certain criteria must be met. And in order to acquire a good test, you have to meet what's called acceptability and reproducibility criteria. Typically, it requires multiple efforts. Minimally, it must be performed on top of everything else with as much effort as possible in a seated position, which they may not be comfortable to start. And patients are typically there for a reason, right? So this means they likely have comorbidities and have been waiting in a clinic for more than just a few minutes. Something I've noticed over the years of seeing patients in the outpatient setting, certain individuals voluntarily place themselves in PO, or they just stop taking their medications just because they figured, well, I knew I was going to the doctor, right? You see all kinds of things in clinical practice, right? I think you can agree, sometimes you just have to expect the unexpected. So I don't want to assume that all patrons on the webinar today are just those already working in a PFT lab. No doubt, we likely have a variety of clinicians and experts on the call today. But that said, let's do a quick reminder of just how taxing these tests can be if they're done correctly. And as you're seeing on the screen, different settings and varieties thereof, but typically a patient is seated, but will have their nose clipped, their glasses removed, and something rather uncomfortable and foreign placed between their teeth. In addition, the patient is asked to breathe a certain way upon command and to keep blowing, keep going, well beyond what is usually comfortable for them. So coughing is a very common side effect of attempting a pulmonary functions test. Dyspnea, even nausea or fainting can occur. And some of you out there have seen that. I've seen patients they thought were coding, but they just had low blood sugar and they had vasovagal syncope or something similar. So you just need to be aware those things, of course, can happen. So this is the most recent comprehensive publication on, as the title states, standardization of spirometry. Now, keep in mind the American Thoracic Society, partnering with the European Respiratory Society, is considered the absolute authority on pulmonary functions testing in the United States. This document, as you can see, was published in 2019 and was a revision to the old original 2005 standards, the iteration in 05. Spirometry is referred to as a test that is, and I'm going to quote from the article here, fundamental in the assessment of respiratory health. So we're talking very general. Its intention or its purpose, speaking of spirometry, if you will, is going to assist with the diagnosis and the monitoring and even the evaluation of disability or impairment. And a few others are thrown in. You can do research, of course, and clinical trials, and even pre-employment screening, for example, are all parts of what spirometry offers the clinician. And of course, sometimes we know that we steer therapies according to their baseline versus how they progress with their disease process. So there's a lot of good value to spirometry, and it's relatively quick, non-invasive, and quite affordable for most insurances. Now, I don't want to get into that. This article was released on the American Thoracic Society's main webpage. And as you can see, this is the type of stuff that doesn't exactly give you confidence, right? I mean, they're saying uncertainty around the interpretation of the tests, which are essentially in determining the extent of respiratory dysfunction. They're saying we just don't have utmost confidence, even if the test is done correctly, that it's going to be a consistent value you can interpret just at face value with utmost fidelity. I mean, that's the hope. But look, we're here for it today, and we're going to delve into it together. So here it is, the ultimate short manual on interpreting PFTs. Well, this is the 2021 pre-release of the actual article. This is the actual article. And it was published on behalf of a partnership, as you're probably aware of, that is between the European Respiratory Society and the American Thoracic Society. It was published online July of 2022, and it's 32 pages of extremely detailed PFT interpretation recommendations. But there's no time to repeatedly pore over this beautiful document. We've got patients to do PFTs on, right? In all seriousness, you can see from the group summary that PFT interpretation has to be accomplished along with clinical expertise. And in consideration of just how different everybody, and I mean literally everyone's body is, how different they are, and you've got to put it into perspective, really the test can still be uncertain even if everything is performed or completed as it should be. And we'll come back to this near the end of today, but I want to remind you that the diagnostic test, the results thereof, is only as credible as the fidelity of the measurement. So yes, you want the technician, the technologist to be well-trained and experienced, but at the same time, there needs to be checks and balances in place to where you don't just get a report and immediately assume those numbers are the patient's numbers. There always needs to be a bit of, I don't want to say cynicism, but trepidation, or maybe a little hesitancy unless you can confirm that the credibility of the measurement is there. So let's lay a bit of groundwork before we begin to delve into interpretation of PFTs. Again, trying to get everyone on the same page, and it's not you I'm concerned about, it's the person beside you, so don't be offended. In short, comparing the most common pulmonary functions test, which is spirometry, also known as just simple spirometry, with what is often referred to as full PFTs, or also known as complete PFTs. They're shown there on the screen compared side by side. You can see that we're measuring very different items. And by the way, a complete PFT usually includes spirometry, or at the least, you wouldn't want to perform full PFTs without doing spirometry first, but really it's up to the ordering provider and dependent upon what is really needing to be quantified or estimated, if you will. So I'm doing my best to be cognizant that there are a lot of acronym used in PFTs, but if you're going to become adept at interpretation, the items shown here on the screen are the main items that you're going to have to be aware of and able to understand. So let's just quickly go through here. You've got the main value, forced expiratory volume over that first second in time. So arguably, even though it says volume, because it's volume plotted over time, it really is a flow rate. You've got forced vital capacity, and then you have the gold COPD criteria, the universal diagnostic indicator of FEV1 to FVC ratio. We're comparing this value to that value, and the absolute number is more important than the percent predicted for that number because it's already a percent, and it's also known as the forced expiratory volume over 1 second percent. And then you have the peak expiratory flow rate, which, if you'll notice, is quite familiar in the asthmatic population because we monitor their peak flows. Well, you get the equivalent of that on a standard spirometry report. On the complete PFT side, we have a few common acronyms I just want to overview quickly here. You have the total lung capacity, and when you hear capacity, you can think volume. Usually it's in liters. You have functional residual capacity. You have residual volume, and then you have lung diffusion of carbon monoxide. And you say, why are we having patients breathing carbon monoxide? Well, the affinity for hemoglobin between carbon monoxide and itself is so high that if the diffusion impairment is not significant, carbon monoxide is going to bind to hemoglobin irreversibly. And we'll come back to that as we move on. So why spirometry? Well, any of you that have performed spirometry on a patient or who have observed spirometry no doubt realize a lot can go wrong. But let's assume for today we're going to perform the test as indicated. As you can see from this relatively general short list, spirometry does have value. It's a relatively inexpensive, low labor, quick, non-invasive, well, except for the mouthpiece, but it's a non-invasive test that can give us great information about not only the patient's current pulmonary status, but spirometry allows for monitoring and surveillance, whether you're talking short-term or over many years. And by the way, spirometry is an OSHA, an Occupational Safety and Health Administration requirement for employees in the United States that are exposed to what they call pulmonary hazards. Those would be things like asbestos or beryllium or certain manufacturing known to emit emissions or dust. So everything you see here on the list, spirometry will allow you in some form or fashion to accomplish. And I know from personal experience that baseline lung function can give you a lot of good information to initially inform treatment. And certainly before you have a treatment plan, you need a diagnosis. Well, again, you can't diagnose singly from spirometry, but it certainly is a part of the diagnostic process. So on a typical spirometry, the values shown are readily available at the conclusion of the test. Now notice both volume and flows are shown. And do recall that mathematically, as I mentioned, flow is simply volume plotted over time. You're comparing how much volume is being expelled, usually, over X amount of time. So what we're really measuring are flows when all is said and done. And spirometry is the gold standard for diagnosing an obstructive condition. It doesn't allow us to definitively say they have X type of obstructive condition, but it can help us towards a diagnosis. And although spirometry alone will not allow diagnosis of anything, it certainly is a piece of the puzzle. PFT is only categorized as a standalone metric. And while we're on the topic, a spirometry can allow a classification of obstructive disease, but again, it cannot allow you to say they have restriction present. Remember, if they have obstructive disease and you're measuring flow on spirometry, they may have lower volume put out over time. That doesn't mean that they have restriction just because less volume is being expired. They could have an obstruction. And so we always need to make sure that we're on the same page. When we talk about spirometry, it only allows you to rule in or to rule out obstructive conditions, not necessarily definitive diseases. You need a complete PFT in order to diagnose a restrictive condition. So again, looking at the values shown here, these are just typical of standard reports. You've got forced expiratory volume, and all facilities have a little bit variation in their software capabilities, but what you're seeing here are fairly universal values available after a patient completes spirometry. You have forced vital capacity. And by the way, the FVC and the slow vital capacity should match identical unless they have obstruction. That's a good clinical nugget to recall. You've got the forced expiratory volume over 1 second plotted over or compared to the forced vital capacity. This is also known as FEV 1%. Now we're going to get into predicted values upcoming shortly, but when you look at absolute values, if they're not put into perspective, they have very little meaning. And so we have a percent predicted that we're going to talk about here in a moment. But what I want to tell you early on is FEV1 to FVC ratio is already in percentage form. And so its absolute value, not necessarily percent predicted, is more important than, say, the other values where percent predicted is what we look at. So we also have the forced expiratory flows at certain points within the expiratory maneuver, and that's where you get that percentage here. So for instance, FEF stands for forced expiratory flow at 25% of the expiratory maneuver. You have the latter portion here, I want to say signal, but it's really a mark, forced expiratory flow at 75% into the expiratory maneuver. And then you have that middle section. This would be like the filet mignon of forced expiratory flow, that center cut of value. And then this is the peak expiratory flow. It doesn't say peak expiratory flow, but you can see the way it's described. It could be surrogate for peak expiratory flow rate. This is the forced expiratory flow max. So I have physicians all the time that say, can you get a peak flow on this patient? Well, if they've just had spirometry, guess what? You just got a peak flow on the patient, or at least very close to it. So it's okay if you use that as a surrogate for peak flow. It actually arguably might be more accurate as a snapshot. And then you have one that's maybe less interesting to most clinicians, and that's forced inspiratory vital capacity. But if you have a tracheal stenosis or a fixed airway obstruction, or maybe an unusual internal to the airway lesion, forced inspiratory flows might be as interesting as well. And then you have the inspiratory flow max equivalent. But again, the top of this list here, what's in bold, is going to be your go-to as we begin to interpret spirometry. And if you will stay with the system, and you will look at it as sort of a mantra, you just do it over and over and over, you'll get really good at it. And so just like interpreting a chest x-ray, an arterial blood gas, or what have you, the more you can stay with an absolute consistent system, the less you're going to miss. And I hope before today's over with here, you'll have some confidence. I got to give you a little more, though, before we get to the good stuff. We're going to roll, don't worry. So before we really dive into practicing interpretation, it's very important to note first that up to date, there's no particular requirement or minimum criteria for actually performing the test. That is saying that for the technician or technologist, basically almost anyone can be on the job trained, and there's really no regulation per se for mandating the person performing the test on patients have formal training or credentials or even licensure. It's kind of disturbing, right? The American Thoracic Society Standards for Spirometry does not recommend training for the so-called operator of the test. For those that do PFTs on children, though, additional specialized training is recommended. Now, there is one saving grace. The American Thoracic Society, in partnership with the European Respiratory Society, their standards for what they call acceptability and reproducibility. So we have this, I guess, minimum quality standard. So let's discuss. This publication released by the ATS in 2019 is almost 20 pages of hands down the most important information on spirometry for any US-based clinician, even beyond the US. Prior to this document, spirometric standards really had not been significantly updated since 2005. So this really should be your go-to, especially if you're just getting into PFTs, or maybe you've just been placed into a position that you are over managing a PFT lab. This will be something to have at the ready at all times, and you can download it for free as a PDF and have it on you, ready to reference. What's interesting, among other things, about the study leading up to this release is they surveyed 1,760 spirometric patients. Now, just a little trivia there. I believe there's 1,760 yards in a mile. Been a while since I thought about that when the number just hit me in between the eyes. But in general, these patients reported the need for information about spirometry before the test. They said, I want to know more about what test I'm about to do, specifically about medication withholding. A significant portion of patients that they found, 31% of these reported the feeling that to keep blowing even though you don't feel anything coming out, to describe a moderate or serious issue. They're saying, look, it caused me great stress and strain to be told to keep breathing out when I felt like nothing was coming out. I mean, spirometry done correctly isn't easy, right? You clinicians out there can agree that you've been doing these a while. By the way, the American Thoracic Society states that with appropriate coaching, children as young as 2.5 with normal cognitive and neuromotor function are able to perform spirometry. Now, look, I got to say, I don't know if I'd want to try to do spirometry on a 2.5-year-old. Would you? Just spending a moment longer on this chart before we move on, particularly note the nuances of both acceptability and what they call usability, or sometimes it's called repeatability, which is repeatability, by the way, at the bottom here, you can see. So specifically, acceptability refers to usability of a single maneuver, whereas repeatability dictates the consistency of multiple efforts. You will never or you should never just do a single effort and take that as the number for the patient. Now, you may not always have the luxury of taking a patient doing multiple efforts in a perfect scenario, and so you only have what you have, but you shouldn't take that one value and make a really high-level clinical judgment from the single effort because there's so much variability. So the goal of today's webinar is not necessarily focused on performing the test, but rather interpreting the results. But you and I certainly recognize that the fidelity of the measurement is paramount. It needs to actually represent what the patient is encountering. Again, this latest 2019 update to spirometry is shown here with the changes to the old ways called out. So here's the gist of the revisions. And, these are just the key updates as shown. So take a moment to soak a few of these in. And of course, you're going to be provided the references with the presentation as we go. You can see it right there on the screen. And then we're going to show more as we go along the way. Probably the biggest one from this list is they're kind of listing a group of activities the patient could avoid or should avoid before testing. And then they've got this new grading system for assessment of spirometry quality. So, it is getting better, but it's still, I don't want to say it's like the Wild West out there, but if you're telling me no one has to be formally trained, it's OJT, and they don't have to have a background in healthcare or respiratory therapy, I don't know. That's kind of one of those things where you have to take it into consideration how experienced the technician might be. By the way, it's worth noting the American Thoracic Society provides an open website to their statements, their key statements, their guidelines, their reports, and you can easily access many of these. And many can be downloaded to your personal device via PDF. And look, I would recommend it if you work in a PFT lab to have those standards of spirometry at the ready. So let's start delving into the interpretation side of things. I know that's where you want to go. And PFT can be kind of dry. I know it's an hour and a half topic today, so we're going to eventually get right into looking at some of these reports, but we need to establish, first off, in order to appreciate abnormal, you have to know what normal looks like, right? There is a difference. This is where a literal reference point comes into play. There's no way around it. There's certainly multiple varying predicted reference sets used, and depending upon your area of the country or the world, and depending upon the device, manufacturer, the software package, etc., the predicteds are going to vary a bit. So have no fear, perspective is everything, right? First off, predicteds are just reference points created dependent upon things like age, sex, height, and race. Weight, although is not an actual determining factor, could also influence lung function results. So do keep that in mind. So what we consider upper limit of normal and lower limit of normal would be 80 to 120% predicted. Now that's not absolute value. We're going to go over this as we move on to some of these reports. So in other words, for any value that is less than 80% predicted, we would say that is a low value for that patient. They're lower than they should be. A 120% predicted value greater than 120% predicted would be considered a higher value or a value higher than it should be for that patient. So predicteds, they take a group of patients that they studied over many years that are considered normal, and they say for this patient's demographics, anthropomorphic values, this is what they should be in every area. And so how far off they are from the mark, that determines what is called percent predicted. Now, the picture shown here was taken a while ago at the time of the tallest living man and the shortest living man. Obviously, the size of the person will ultimately determine the size of the thorax. The larger the thorax in length, that is, typically the larger the lung volumes. Recall that because volume over time is the mathematical definition of flow, a person with larger volumes will usually be able to produce higher flows. All that said, what really matters is age, sex, height, and a close fourth would be race. Weight is in parentheses here, and again, it might be an influence over lung function results, but it is not considered part of the literal predicted calculations. Now, luckily, the computer calculates percent predicted. Again, I told you we wouldn't do a lot of math today. By the way, the NANES 3, the third version of what is known as the National Health and Nutrition Examination Survey, they conducted it over about a 5 to 6 year period from the late 80s to the early 90s. And man, that was some good times back then. But it's still one of the main standards of reference for many diagnostics used today, even outside of PFTs, called the NANES, and they're on their third iteration, the National Health and Nutrition Examination Survey. A good visual is always helpful, and even those of you on the call with many years of PFT experience, it just helps to sometimes see it all labeled, right? You see it all the time. You see the tracings, but to kind of go back to the future here and see it labeled once again. Here we have a very basic volume over time tracing where you can see that tidal volume is proportionally very small compared to vital capacity, which recall that vital capacity is the maximal amount of volume you can move in or out of your lungs voluntarily. Basically, during spirometry, you can measure either slow or forced vital capacity or both, right? And by the way, both slow and forced vital capacity should be identical unless there is obstruction present. If FVC is less than SVC, in other words, force is less than slow, either the patient has poor effort or there is actual obstruction present. And that's just one more clinical nugget to consider if you work in a PFT lab. All right, so here it is. Let's look at our first spirometry report. Do recall that acceptability, also known as usability, and then we have repeatability criteria mentioned by the ATS in their latest 2019 update. It should be confirmed before jumping into test interpretation. So you just have to trust the person here. And I don't know if it's showing there at the top. This is not one I did. I've got a couple I've done coming up. But I know this tech, she does very good work, and it says meets ATS standards for acceptability and were reproducible. So the credibility has to be assumed is present. And per the 2019 update to spirometry, by the way, spirometers are also now required to meet international standards, but with a maximum permissible accuracy error rate of about 2.5%. So nothing's perfect. Values are typically acquired in consideration of what is known as body temperature, ambient barometric pressure, and saturated water vapor. Have you ever seen BTPS showing up on your reports? That stands for body temperature, pressure saturated. In other words, it's at body temp, saturated water vapor. And anytime you're talking about lung volumes, we assume we're at that level. And if you worked in a PFT lab for any amount of time, you recognize that ambient temperature and barometric pressure and even humidity levels should be recorded at least once prior to each test day. And hopefully you're doing that out there. So let's concentrate on what we have shown here. For starters, again, we want to make sure the patient's height and weight matches what we visualize in their medical record, because if this gets typed in wrong to the EHR, the predicteds are going to be calculated in error. Age is there, race, sex, all of that. So once we do a quick verification that, okay, we know the tech, maybe they've got credentials, maybe they don't, they do. Height and weight, age, sex, race, we move on. Any pertinent notes here? Okay, acceptability, reproducibility was met criteria, and now we can say, in theory, it's a credible test. So here on our software at the time, we had pre-exercise, post-exercise as umbrellas, but what we're really after here is just the spirometric results. We have the actual column, that's what the patient actually did. Predicted is based upon normal values for similar patients, and then percent predicted is comparing what they did to what they should have done. And so if you want to pick one out and do the math right now at your desk there, let's pick out one where you can clearly see that their actual is above their predicted, and that's why you have 123%. Now, even though we're above 120% predicted for one of the values, and we have one value down here that's below 80%, so there's varieties of very mild abnormality, most of what you're seeing here is a fairly normal spirometry result. But let's look at it systematically. So first off, you're going to look at your top values here, your forced vital capacity. The patient was expected or should have done 4.14 liters. They actually did 5.10, comparing what they did to what they should have done. It rendered 123% predicted. In other words, they are super normal, if you will. They were above the upper limit of normal for forced vital capacity. Now, this could be somebody that is working really hard, giving max effort. Maybe they did something they shouldn't have done, and they retched, or they bent over and they splinted themselves, so they helped their abdominal muscles compress or shorten. That's something that you see from time to time. You get somebody with a family member they're really trying to impress, or they're trying to prove the ordering provider wrong. I don't have lung disease. sometimes you'll see that. So I'm not too concerned with a little bit above the upper limit of normal. I would be more concerned below. FEV1, they should have done 3.29. They actually did 3.82. Even though they're above 100%, up to 120% predicted is still considered normal. Now here we come to the arguably most important value for ruling in or ruling out obstruction. You've got FEV1 to FVC ratio. Again, this is forced expiratory volume over 1 second, this value here, in other words, the 3.82, compared to the forced vital capacity. In other words, for this patient, the 5.10. So if I mathematically just take it, put it in my calculator, 3.82 divided by 5.10, I would get 75%. Now, if that number is not below 70, you cannot rule in obstructive disease. Now, to put it into perspective, look at the percent predicted. They are 95% predicted. In other words, they're 95% of what we would expect. So once again, that confirms there's no abnormality here. And as you look at the other values, I'm not going to spend a lot of time on these because we could endlessly interpret reports, but I do want to jump down to forced expiratory flow max. Again, surrogate for peak expiratory flow. They should have done 8.63. They performed at 8.76. That's 102% predicted. This is really as close to normal as you're going to get. And I wouldn't expect too much. They had no history of smoking, fairly young for a patient as it is in pulmonary. And if you look at the flow volume loop here, these dots are predicted values that line out what it should align with. This is your volume over time tracing. ATS criteria favors 6 seconds or more effort on expiration. And you should see a flattening, a plateau, and eventually we do get it right here at about 6 seconds. So fairly close to being normal. As a reminder, this is your most important portion of spirometry for interpretation purposes. We're going to practice more as we go. For FVC and FEV1 individually, percent predicted is the most important. But for FEV1 to FVC ratio, the actual value is most important. We're going to come back to that. Again, just a reminder, this is the detailed summary, kind of an oxymoron, it's quite detailed, of the basics of spirometry. Interpretive strategies are discussed more in detail in this next document. Both of these should be a part of your repertoire. Do you have to read them cover to cover? Certainly not. There's summaries, there's great charts, but these are just recently updated in the last few years. It's worth a read, worth a glance. Just a great reference at face value of the varying shapes of flow volume loops associated with particular conditions or disease types. Of course, the larger upper left flow volume loop would be the reference of normal here. That's what the shape, the morphology should be. And you can just see in general, again, you're going to have a copy of this PowerPoint set, and hopefully you can use it as a good reference. Here's another great reference. At the top, you've got volume over time. And you've seen all of this on simple spirometry. You've got volume over time scalar with associated flow volume loops shown below each type of volume time plot. Note that perfect normal is superimposed as the dotted line tracing on each graphic. So it's just giving you something to compare the abnormality to. That's what it should look like. Basically a lopsided inverse ice cream cone. You can see how far you are from the mark based on the disease process. Now, with a mixed condition, you can see it's got the scooped out appearance, there's tapering flow on expiration, but also a diminished volume. You'll see with restrictive disease, they plateau very early. With obstructive disease, they may not ever plateau. Just a good clinical nugget. Take a moment here to note perfect normal to the left. This is known as acceptable with what each portion of the tracing represents. Again, a good reference slide for today. Would you need to memorize it? Certainly not. As far as I know, there's only a fun little quiz at the end, but no major test. On the right side, we have obvious unacceptable flow volume loop, and various reasons for such are numbered and labeled. The flow volume loop should always be closed. That's why it's called a loop, right? And it should be continuous as shown on the left, unlike the open loop with the large gap here shown on the right. Here's a very nice volumes and capacities box drawn aside a volume over time tracing of the actual typical spirometric maneuvers during simple spirometry. Note, beginning at the far left of this picture, the patient is breathing at tidal volume, and that's what you want. You want them at rest, breathing. I usually tell the patient when I'm doing PFTs, It's like you're sitting on the porch, relaxing, feeling the breeze. Just breathe in normal, real relaxed, in and out, real relaxed. And the patient is instructed suddenly to begin to breathe in as deep as possible. And we want to take them all the way to total lung capacity. That is really the goal. And then immediately there's to breathe out as much air as possible, hard and fast, down to their, in theory, their residual volume. This would be a good visual representation of a slow vital capacity, although many times we want their forced vital capacity as well, part of typical spirometry. Here's a bit more detailed version where you can appreciate a patient's breathing pattern and what is actually not directly measured. For instance, the residual volume, as the name would imply, residual volume is the volume left in the lung at the end of maximal exhalation. Note again the particular proportions of each volume and capacity in comparison to the others, particularly in comparison to the total lung capacity here. Each measured volume or capacity make up a certain portion of the total lung capacity. So total lung capacity cannot be directly measured on spirometry. You have to have body plethysmography. They have to be in the body box. For what it's worth, spirometry primarily measures flow, but the machine can calculate various volumes or capacities based upon the mathematical principle that flow is simply volume plotted over time. Give you a little brain break here. This cast of the bronchial tree is formed of inspissated mucus and was coughed up by a patient during an asthmatic attack, very famous case study. The outpouring of mucus from hypertrophied bronchial submucosal glands, you got bronchoconstriction and also dehydration, they all contributed to the formation of mucus plugs that can block airways in asthmatic patients. Although, yes, at certain times a spacer or holding chamber may be hard to come by, or you have a non-compliant patient who refuses to use one, anytime a standard pressurized meter dose inhaler is used, a spacer should be employed. Even with our current HFA propellants, the medication exits the device with such velocity that patients lose a significant portion of their medication to the posterior oropharynx when a holding chamber is not employed. Now, we have the Respimat, of course, and that's been a game changer. Love the Respimat just because it doesn't require a spacer. There are various iterations of spacers, also known as holding chambers, on the market, but regardless of structure or design, any spacer used would likely be superior to simply just utilizing a pressurized MDI without one. Remember, particle size, flow pattern, among other things, they greatly influence how much aerosol is deposited and whether it reaches its intended destination. And yeah, spacers can be used for just about anyone or anything. So moving along, before we get back into practicing PFT interpretation, worth mentioning is the pre-post bronchodilator study. This is also known as bronchodilator responsiveness testing. Now, according to the latest 2019 ATS update, clinically, if their FEV1 is greater than 75% predicted, there is no indication for post-bronchodilator studies. I have seen physicians and other ordering providers that want a post-bronchodilator study regardless, just to see if the patient improves, and that's okay. It's their prerogative, but it's not recommended if their FEV1 is greater than 75% predicted. Now, if you recall, 75% predicted is still below the lower limit of normal, but according to indication for this test, they wouldn't meet criteria. So what you're essentially looking for during bronchodilator responsiveness testing is a patient's ability to show improvement in flow rates after the administration of a bronchodilator. This usually involves a baseline spirometry to start. You administer an MDI or nebulizer with a medication such as albuterol or Atrovent. There's a waiting period, and then you retest the spirometry and you compare the results to the baseline. Mainly, you're looking for a so-called significant change. Now, this is one thing that's changed since 2019, that new publication. We're looking for an improvement in FEV1 or FVC individually of at least 10%. So it used to be 15, then they said 12 to 15, then they said 12. It is now, if we see an improvement in FEV1 or FVC of at least 10% above the prior baseline, then they have a positive response. So we're going to practice coming up. There are, of course, other flows such as FEF 2575 that can be evaluated. Also, a patient might feel very different, as if they've improved and are breathing significantly better for them after they've had the bronchodilator. even if the number criteria of at least 10% improvement may not have been met, and that's okay. Maybe they should still be prescribed a bronchodilator. They don't have to meet ATS criteria to be prescribed something that they feel better after taking, as long as the ordering provider is okay with it. So let's take our time here and evaluate first the spirometry shown to the left. So look at it as just a single spirometry. This would be considered also a pre-bronchodilator or baseline. This is one that I did personally. So patient had good effort, stated she took 2 puffs albuterol taken with spacer this AM, did not meet necessary reproducibility, repeatability, and acceptability criteria. So that was not placed in the report. So, take it at face value, but we had a long-standing history with this patient. So they were unable to perform the test up to the standards, but they gave it their all. So as you see here, this is what they actually did. This is what they should have done. And this is the comparison of the two. So I'm more interested, again, for FVC and FEV1 to look at percent predicted. So here, both are remarkably low. They're well below 80% predicted, so they're both decreased. The FEV1 FVC ratio absolute percentage is decreased as well below that 70 mark, to indicate they definitely have presence of obstructive disease. And just to confirm, look at their peak flow equivalent, FEF max. They're only about 1/4 of what they should be. They're 26% predicted. Absolutely, we can say, we can rule in obstructive disease. And you can see they have a long history of smoking, and they say they're short of breath after any exertion. So the more information you have, the better, but these reports are quite limited. So we chose to do a post-bronchodilator study on this patient. And if you look here, there wasn't a lot of change in every area. You can see the FEV1 FVC ratio actually didn't change hardly at all, but we do meet criteria here, if you see. So post-bronchodilator, post-treatment evaluation. Recall that improvement in FEV1 or FVC of at least 10% would be considered a significant response. Note only a change of 100 mils as opposed to the typical 200 mils requirement with lower overall FVC. It's just the percentage that matters. You're dealing with very small volumes in patients that have extreme obstruction. And so what we're really looking for are the changes that we see here. But what you can see is we've had an increase in both FEV1 and FVC, at least 10% on both. So this patient had a significant response. You can say with confidence this patient had a positive bronchodilator response. So they have obstructive disease, and they responded positively to bronchodilators. And that's about all you can really say from the test, unless you know their full clinical history. Let's look at another. Stay with your step-by-step method to avoid missing something key. Just as before, we'll begin with interpreting the right side or baseline spirometry, the pre-bronchodilator study, and we'll go through and interpret it systematically. So very quickly here, I can see FVC, FEV1, both less than 80%. It does meet criteria as well here for absolute percentage for FEV1, FVC for obstructive disease. And if I look at post-bronchodilator, neither one increased at least 10%. They did not meet ATS criteria. So although there's a small improvement in both FEV1 and FVC, it does not meet ATS criteria for at least 10% improvement post-bronchodilator. And you can see that our flow volume loop is much smaller than it should be. Notice the predicted dots here. And the novice may glance and say, well, they have restrictive disease. There's less volume than we would expect. But remember, with obstructive disease, because we're measuring flows, volume over time, less volume is being expelled over time. And you may see a flow volume loop that almost at face value looks restrictive in nature, but we cannot say diagnostically they're in a restrictive category unless we get complete PFTs. So just some food for thought. Be aware of the last medication that they took. That's why it's important. If they've taken it in the parking lot, they're probably max bronchodilated. But you know what? Not everybody takes it correctly. Maybe they didn't use a spacer. Maybe they did like the TV show one time where they took out the MDI and said, I always put it on the back of my throat, and they did the back of their neck. I've actually seen that live as well. And a bronchodilator may not be effective for all patients, even though we like to order bronchodilators. So switching gears a bit, we're now going back to look at a test that seeks to cause bronchospasm in a controlled setting. Guidelines for this test really haven't been updated since 1999. You may be more familiar with this test, oftentimes called the methacholine challenge test. Only recently, the European Respiratory Society in 2017 did a mild update Rather than basing the test result upon a methacholine concentration, they're recommending that you look at what's called a 20% fall in forced expiratory volume over 1 second. So it's called provocative dose 20. In other words, the new recommendations base the result upon the delivered dose of methacholine causing a 20% fall in FEV1 rather than the concentration itself. So at what point? And we'll kind of come back to this. So you're going to administer an irritant. They're going to go into bronchospasm. The earlier they go into bronchospasm, the more sensitive the airway. Do keep that in mind. And test requires minimal inhalations over time, usually subsequently, and you're monitoring their degree of bronchospasm along the way. So you're doing multiple efforts after a dose. So a dose, let it settle, do an effort. You do a dose, let it settle, do an effort. And so you really need to watch these patients closely. So methacholine is a parasympathomimetic. So it stimulates the parasympathetic nervous system. It's a non-selective muscarinic receptor agonist. And that's a lot. It's a mouthful on this long hour and a half of PFT overview. But it stimulates the parasympathetic nervous system. And so recently, since about 2016-17, there's been a movement more towards, again, the dose rather than the concentration. So rather than basing the test upon a methacholine concentration, we're looking for a fall in forced expiratory volume in 1 second of at least 20%. And that's what that so-called conversion entails. So with the post-bronchodilator, you want to see FEV1 or FVC individually increase by 10%. But for bronchoprovocation, we want to induce bronchospasm and see FEV1 fall by 20%. So what we're doing is not necessarily diagnosing anything specifically from a single test, but we're confirming whether airway hyperresponsiveness is present. Of course, this may lead to a diagnosis such as asthma, and that's what we want, a definitive diagnosis eventually. And there's all types of substances you can use. Some are irritants, some just dry out, they desiccate the airway. But either way you look at it, it is an airway irritant that induces bronchospasm. That's the goal of this test. So this test is a bit more complicated. We're not going to spend a lot of time here because we need to get to the complete PFT here shortly. But for a bronchoprovocation test, you're essentially administering an irritant in successive doses many times. The irritant amount dose progressively is increased until either a predetermined stopping point or there's no real reactivity, or the dose increases and the significant reactivity is achieved. So the significant reactivity, recall, is when there is a 20% fall in forced expiratory volume in 1 second. So here you can see this was achieved, this 20% drop in FEV1. It actually hit 30 before we were able to capture it. But it's worth noting that patients that have the most sensitive airways, the highest reactivity, so to speak, they're going to convert or go into bronchospasm at the lowest dose of irritant. And some patients, even before giving them a dose, we just put the diluent in there, just the normal saline, and they convert immediately. Those are the really sensitive patients. And I know this is a busy report, but concentrate on the dose at which this patient converted. This is when they went into bronchospasm at a significant level, so it occurred at the highest dose. So in summary, we would say this patient did respond to the irritant. However, it took the highest dose to evoke the response. Therefore, they would not be considered at the most sensitive level, although they may have reactive airways disease nonetheless. The idea is to consider so-called cumulative dose units. You can see visually here that same patient where they suddenly drop off at the 5 milligram per mil mark. And after a test such as this, we send the patient into bronchospasm under controlled conditions. We need to then reverse them out by giving them a bronchodilator and confirming they're back at their baseline. You can't just release them from the PFT lab after inducing bronchospasm. So anytime you do a bronchoprovocation test, a methacholine challenge, you have to do a post-bronchodilator to assure they're at or near baseline. So in summary, before we move forward, we have quickly overviewed 3 separate tests: spirometry, the pre-post bronchodilator, and then the so-called methacholine test. Again, for the bronchodilator responsiveness test, we're looking for an improvement in FEV1 or FVC of at least 10%. It should increase, it should get better. But for the bronchoprovocation test, we're looking for a decrease in FEV1 of at least 20%. It should get worse. So let's get to the complete PFT. The complete PFT, also known as a full PFT, starts with spirometry but includes the measurements of all available volumes and capacities. Now, to be clear, certain volumes and capacities are estimated based on a number of equations and what I consider auto calculations that the computer is going to do for you. Honestly, with the recent proliferation and acceleration of artificial intelligence, I wouldn't be surprised if in 20 years this discussion will include an option to have PFTs performed by a robot. I mean, I'm not saying it's a good thing, but it's where we are. So what's shown on the short list here are the main items of interest that give added value to the complete PFT. You've got lung diffusion of carbon monoxide here at the bottom, which is an estimate of diffusion ability or capacity. And in particular, this can be teased out as a separate test, but it's usually included as part of the full PFT measurements. So that said, let's look at what we call the box. Now, this is a great resource, one you should have memorized if you work in a PFT lab. Even if you don't work regularly doing PFTs, it's a great reference to lend perspective. When you're considering pulmonary diseases and the implications of the changes in normal to their volumes and proportions, it's a good perspective. So what you have shown here is normal values and normal associated proportions. This is also affectionately known as the box, and although residual volume is shown twice, we of course only have one residual volume physiologically, but how could we call it a box if it wasn't near square, right? All right, we're getting there. We're getting to the good stuff here. Just stay with me. I know it's a long webinar here today. Lots of good stuff to come. Here we have a complete full PFT, as it's known, with simple spirometry. And you've got simple spirometry at the top. And in the red box here, you have what is known as the complete PFT portion along with the DLCO. And as mentioned earlier, every institution may be slightly different in their software and their reports and their formatting, and we understand that. But just always start with spirometry and go from there. Break down each section individually, just like you would any diagnostic test, and you won't miss anything. Now, for today, we're not going to delve into the granular detail of each obscure optional value. We're just going to hit the main ones that are usually evaluated consistently across the board on most reports. So let's look at this. Stay with your system here. So we want to verify the patient's demographics, anthropomorphic values. We'd like to see they met both acceptability and reproducibility criteria, and we go right into interpreting the test. So FEV1, FVC at the top here, I'm looking at percent predicted. It looks like both are less than 80, they're decreased. I look at FEV1 to FVC ratio, absolute percentage is not less than 70. And to put it into perspective, it's actually normal. So I'm already thinking they don't have obstruction, they have restriction, but I can't confirm it until I look at complete PFT values. One more thing before we move on, if you recall, is the peak expiratory flow. It's on the edge, but it's slightly lower than the lower limit of normal. We expect 80 to 120% predicted. It's less than 80. That tells me, okay, it could be mild obstruction, but it doesn't meet goal criteria, or it could be restriction because volume over time is the definition of flow. So let's look at lung volumes here. The end-all be-all is going to be the total lung capacity, and I immediately see it's less than 80% predicted. That tells me they've got lower than normal volumes, so they have a restrictive condition. What confirms it even more, if you look close here, is their slow vital capacity is at 2.24, identically with their FVC at 2.23. I mean, 0.01 off. That's as identical as it gets. So when your SVC, this is something worth writing down if you have not heard this already in today's webinar. When FVC and SVC align, almost 100% of the time, you can rule out obstructive disease if the test was done correctly. And so we're going to go down to DLCO. You have corrected and uncorrected. In my institution, we just look at uncorrected. If you have the ability to draw blood and all these other things, then that's a different story. But you can see here they are below 80% predicted. They have a diffusion impairment as well. And they also have, just worth noting before we move on, this airways resistance value here. They have a slightly higher than normal airways resistance. Our physicians don't look at this quite as much. They just look at spirometry and complete PFTs with lung diffusion. So we can only say that this patient has no evidence of obstructive disease by gold criteria, by standard criteria. They have restrictive disease with a diffusion impairment. Not much to it. You just have to stay with your system. So here's the same patient's report we just looked at with a flow volume loop shown at the top. And you can see it's much smaller than it should be. Those are the predicted plotter dots. And you can see the flow scalar here, volume over time with a little flow scalar. They plateau very early. You can see where the slope of the line dissipates much less than 6 seconds. That usually indicates restriction as well. But again, you have to look at complete PFT values, your volumes. So at the top graphic here, you've got the flow volume loop. That inspiration is slightly dampened. It could be effort dependent or, could be a true abnormality. Also note how far off the actual flow volume loop is, again, compared to the predicted dots. Just a really good reference slide. I'm trying to redeem a bit of time here as we go. Another good reference slide. If you just had to generally at face value divide the two categories, with obstruction, you're going to have decreased flows. That's the trademark. And with restriction, you're going to have decreased volumes. And you say, well, I thought volume over time was flow, and you're correct. We still look at some others if we have them at our disposal, but those are just kind of the general ways of viewing the two categories separately. So here's another good chart. It's a good quick reference. It highlights a few key indicators that differentiate between obstructive and restrictive. Keep in mind certain patients may have mixed conditions, and those are a bit more difficult to appreciate on PFTs. Another good visual for reference, redeeming a bit of time here. You can see with obstruction, it is the flow that is impaired, but our volume may be maintained. In other words, give them enough time and they can expel their volume. But with restriction, they just don't have the volume to expel. And you can see the volume here is diminished, and therefore your flow overall is only slightly diminished. Again, the trademark of obstructive disease is diminished flow. The trademark of restrictive disease is diminished volume. So for most of these next few upcoming, the category will be shown at the top to give you a bit of reference. The more detailed interpretation will be shown at the bottom, but let's practice first to test your technique. So I'm going to give you a moment to look at this one and decide how you want to interpret. Give you just a moment. Give you a hint, start with FVC, FEV1 and the ratio, and start on the baseline side. I'm going to look at percent predicted, and I'm going to look at absolute value. Now be careful, the columns have changed. This is a different software. You're all at different institutions. The predicted column is not what they actually did. This is what they actually did. So for FEV1 to FVC ratio, you want the absolute value. And you can immediately see they have obstructive disease. The overall interpretation, because they did have at least 10% improvement, and you don't have to have 10% improvement in both, one or the other, or both is fine, but they had significant post-bronchodilator improvement. And the severity categories we're not delving into today. I just want you to leave with a little something rather than a lot of nothing. So let's look at another one here. Stay with your system. First thing I'm going to do is look at percent predicted for FEV1 and FVC individually. They both are low. They're less than 80%, below the lower limit of normal. The absolute value for FEV1% is 49. It immediately meets criteria for obstructive disease. And I can see I've got a 15% increase, which is good. So they have a significant post-bronchodilator improvement. Doing one more, staying with your system. Both of these are less than 80%. It meets criteria for we suspect obstruction, but what confirms it is my FEV1 ratio. This one's a little more involved, so you've got complete PFT values as well. So notice your predicted column here, your percent predicted, so this must be the patient column. And you can see we've got post-bronchodilator and, of course, full PFT results with diffusion studies. So stay with your system. Both FEV1, FVC are decreased. My absolute value for FEV1%, though, is normal. It's not less than 70, and it is absolutely normal by sheer absolute value. So there's no presence of obstruction that I can tell. We do have a slight diminished peak expiratory flow, but by the way, that can be a process of restrictive disease as well. So because I have complete PFTs, I immediately go to total lung capacity. I'm at 41% predicted. I'm less than half of what I should be for total lung capacity. That tells me immediately they have restrictive disease. I go to my lung diffusion study, less than 1/4 diffusion ability, and they have a pretty significant diffusion impairment. Did they improve post-bronchodilator? They actually went down. And you see that on occasion. Somebody takes a bronchodilator and just the cold air, it irritates. Maybe they went into bronchospasm. It didn't do them any good. But what we have here is a restrictive disease with a severe diffusion defect and no post-bronchodilator improvement. I love this one. Let it sink in a minute. You've seen these patients, right? So in this next one, just basic results here. Irrespective of what your institution shows on a report, if you can get down to these values, you can tell immediately within moments whether they have obstruction or restriction. So their FEV1 and FVC individually are decreased. Their ratio meets gold standard, less than 70. They have an obstructive condition, and their total lung capacity is diminished as well. That usually tells me they have a mixed restriction with an obstruction. Here's a 75-year-old male. Looks like both FEV1 and FVC individually are less than 80% predicted. Their ratio meets gold criteria for less than 70%. They have obstructive disease, and this is confirmed that they also have hyperinflation. So when total lung capacity is above 120% predicted, they are hyperinflated. So obstructive disease with hyperinflation. This one's busy, I know, but stay with what you know. You've got the reference value. You've got the pre. This is not predicted, by the way. It gets a little sketchy on this report, but I wanted to give you several varieties of different hospitals you might see, and then you've got percent reference. So when you see percent REF, that tells me that has to be your predicted, that's percent predicted, and that's what the patient did. So staying with our system, FVC, FEV1, percent predicted, they're both less than 80, they're low. Your absolute value is 35. They definitely have obstructive disease. I go down to my total lung capacity, very slight increase in total lung capacity. That rules out restriction right there. They absolutely have obstructive disease. And in this patient, look at their residual volume, percent predicted, more than double what it should be. This patient has obstructive disease with air trapping. And look at their lung diffusion study, about half of what it should be. They also have a diffusion impairment. Worth noting before we move on, look at their airways resistance, 333% predicted. So this patient has obstructive disease with air trapping, diffusion impairment, significantly increased airways resistance. It looks like they did a post-bronchodilator, so before moving forward, we can see they increased 8% for FEV1 and 24% for FVC. All you needed was 10% increase in one, so they also have a positive post-bronchodilator response. Here's another one. Stay with your system. Take a moment, and I'll talk us through it. And I realize we're moving fast, but we're staying with the same system every time. You've got lower than normal FEV1 and FVC individually, but your ratio is actually normal, so there is no presence of obstruction thus far. I go down to my total lung capacity. There's the answer. They have restrictive disease. It's circled here. 35% of what they should be for total lung capacity. Pretty significant diffusion impairment, less than half of what they should be, only 47% predicted. Yes, they have increased airways resistance. And no, they did not improve post-bronchodilator. They actually got worse. You'll sometimes see that pattern where they actually get worse after bronchodilator with restricted disease just because you've irritated the airway. They're not able to take deep breaths like you and I, and so it's difficult. Notice their flow volume loop, how small it is as well. Here's another one. Stay with your system. Divide it up. This is your baseline spirometry. This is your post-bronchodilator. So you can see percent predicted. It looks like they have a normal percent predicted for forced vital capacity, but a lower than normal for FEV1. Look at your ratio. What does it tell us? Less than 70, they have obstructive disease. Total lung capacity confirms they do not have restrictions. So everything is pointing to obstructive disease. And let's go down to DLCO. They actually do not have diffusion impairment. They do have high airways resistance, and their post-bronchodilator, they just barely met criteria for significant response. So this would be a patient with obstructive disease, no restriction present, no diffusion impairment present, and a very by-the-book minimum criteria post-bronchodilator response. A couple more, and we will move into the last section here, give you some more time to practice. So you've got 87% predicted for FVC, 49% predicted for FEV1. And by the way, on this slide, every asterisk represents a clinically important value you may want to glance at. There is some debate here with the FEF 2575, which is why we haven't discussed it. It's not as sensitive an indicator as the others. So staying with our system here, they are at 87% predicted for FVC baseline, 49% predicted for their FEV1 baseline. Their ratio absolute value for FEV1% is decreased, less than 70. They immediately meet gold criteria for obstructive disease indication. You can see total lung capacity is normal, 80 to 120% predicted. They do not have restrictive disease. Their residual volume is 150% of what it should be, so they do have some air trapping. They have obstructive disease with some air trapping. They have mild diffusion impairment because they're only 65% of what they should be. They should be 80 to 120%. Look at their airways resistance here, almost 6 times what they should be. This patient, I can guarantee you, has dyspnea upon exertion. They have lower than average quality of life, and they are struggling when they exercise. And they did have a positive bronchodilator response. You see that 10% increase in FEV1. So this would be a patient with obstructive disease, somebody that has air trapping, mild diffusion impairment, significantly higher than normal airways resistance, and a very slight but positive post-bronchodilator response. See if you can do this one before I interrupt. Stay with your system. A few more seconds here. Again, there's much more to see and do here. We're staying with our system, and it will give you insights very quickly at face value what really is happening. So both FEV1 and FVC individually are decreased, but you notice my ratio absolute value is well above 70, and it actually is in perfect normal range. So I know I do not have obstructive disease present. My total lung capacity confirms I'm below the lower limit of normal, which is 80% predicted. That indicates mild restriction. And I can see from my DLCO, I also have a mild diffusion impairment. You're thinking about things like pulmonary fibrosis, interstitial pneumonitis sometimes can have some residual effects. Airways resistance is normal. So again, all of this is basically screaming, no obstruction, no obstruction. I have very mild restriction. And you can see the flow volume loop shape, the morphology is almost a perfect, slightly lopsided inverse ice cream cone, but it's just smaller than you would expect. So in all, you can also see there was no increase post-bronchodilator. They actually went down on one of their values. I'm not saying it always follows this rule, but a majority of the time, you will see somebody decreases post-bronchodilator with restrictive disease. It's just a phenomenon I've seen over the years. Doesn't always hold true, but you'll see it. So what's the interpretation here? This is a different institution, different report, but I want to challenge you a bit. I don't want to give you just what my institution does. I want to show you what other institutions in our area, how they print the report. So don't get too bogged down here. You've got predicted value and you've got observed. Here's what they've done and their percent predicted. So again, start with FVC, even though you got much more to look at here. I am 68% predicted for FVC baseline. That's low. I go to FEV1, I'm 62%. That's low. So both are low. And then I go to my absolute value for FEV1 to FVC. It's at 74. So it's less than 80, but it does not meet literal gold criteria for being less than 70. So thus far, I cannot rule in obstruction, and I can't rule in or out restriction. I go to peak expiratory flow rate. It looks like 57% predicted. So their peak flows are lower than normal. But as I mentioned earlier, that could be an indication of obstruction or restriction. Let's get down to what gives us the most information that we need here, the total lung capacity. It's 95% predicted. They certainly do not have restrictive disease. They do not meet gold criteria for obstructive disease. Yes, there's some abnormalities present. And yes, they could have, if I recall off the top of my head here, PRISM, which is spirometry is normal, but they have evidence of obstructive disease. And what I find is interesting is they've already got a diagnosis up here of COPD, but their spirometry does not absolutely align with that diagnosis. Now their DLCO, lower than normal, they do have a diffusion impairment, and notice their percent change, FEV1, 5%, FVC actually went down 1. So there is no evidence they had a positive post-bronchodilator response. There is no gold standard criteria on spirometry. They have obstruction. This is one of those patients that needs to be followed over time. They're on the cusp of having COPD. And yes, they already have a diagnosis, but their spirometry does not indicate that they absolutely have COPD. You and I know once a patient is told they have COPD, they hold on to that the rest of their life. So here's a fairly simple one. Let's go full circle back to just spirometry, no bells and whistles, and use your technique. Lower than normal FEV1, FVC individually, quite low. Look at their actual ratio. Immediately you should be thinking obstructive disease. And look at their peak flow, forced expiratory flow max, 1/5 of what they should be, 20%. Look at their flow volume loop, how dampened it is. And look, it looks like an airplane taking off from the runway. They never plateau. Now, we should have went 6 seconds, but I can argue they probably did not have the ability to go the full 6 seconds. Sometimes they give you all they have. And if they have very little reserve, this is what you get. Let's look at this one. I'll give you a moment to take a glance. Once again, talking through here, FEV1 and FVC individually, each are right on the normal value, 80 to 120% predicted. Actual FEV1 is below 80, but it doesn't meet the gold COPD criteria for less than 70 to say they have obstruction. This is a fairly normal PFT. They have one value that is quite low, and it's the forced expiratory flow at 72%. What you're seeing more and more of, deconditioned patients, they don't have the stamina, the ability to sustain that abdominal muscle contraction when they do that full effort, even though they're giving you all they have, they just don't have the stamina. Some patients with diabetes, they have capillary dysfunction in their musculature. There's a lot of things at play here, so don't get caught up in picking out one abnormal value and hyper-focusing and saying this has significant clinical relevance. It could just be a nuance or a confounding variable. You need to stay with your system. FEV1, FVC, look at the FEV1%, the ratio. You can look at peak flow equivalent. And then if you have a complete PFT, of course, you would look at that as well. So here are two compared side by side. So if you look at these patients, you've got one here, very low on FEV1, FVC together. That's the one we just looked at, have obvious obstructive disease. You can see again, dampened flow volume loop, and we never plateau on volume times scalar. Then you come back here, notice the dates 10 years apart. What I'm going to tell you is this is the same patient. Do you know what happened with this patient? They went from pretty significant COPD to near normal. So they had a lung transplant in 2004, years ago. I'll never forget this patient. So what I can tell you, they say the worst thing about a lung transplant, the best thing is you breathe better, your pulmonary functions improve, and you get a second chance at life. The worst thing about being a post-lung transplant patient, it's the first time you cough up somebody else's mucus. So I'd be remiss if I didn't mention that the Global Initiative for COPD organization has a very nice, relatively concise 14-page, fairly comprehensive and downloadable summary document that includes a really good overview of pertinent PFT values. And as you can see here, they provide a chart that dictates COPD severity per spirometry criteria. Just a great reference to keep you aligned. I love this one. Not everybody that smokes gets COPD, but a majority of those who have COPD have smoked. Okay, so let's just quickly go through a few more as we near a close today. For this one, just a reminder that not all diagnostic tests show an abnormality. Here we have as close as you're possibly going to get to a perfect normal spirometry. Note that all percent predicted values in the far right column here are within 80 to 120% predicted, except for this one right here, this FEF 2575. Every human being has a bit of variability, okay? If you're looking at all normal values except one that's slightly askew, it's probably a normal PFT. Now, the flow volume loop at the bottom left shows the predicted dots. It follows the predicted dots, and it appears as a slightly offset upside down ice cream cone to the left. And then to the right, you've got volume over time, scalar, and you can see there's a beautiful plateau very early on between 3 and 4 seconds. There's no slope in that line, and it's very smooth as it plateaus. So what you also have, I didn't mention until now, you've got that FEV1 mark. There is forced expiratory volume over time at 1 second. That's the mark there. And you can see that they went the full 6 seconds, and that usually meets ATS criteria. And of course, the technician, technologist said acceptability, reproducibility were met. I mean, it's a fairly younger person, younger female. The question is, why are they getting spirometry? Well, back to that short list. Maybe it's a pre-employment screen. We get disability claims on occasion, things of that nature. So it doesn't always mean you should expect disease. Some patients are actually normal, even though they're a patient. So let's look at this one. The one you saw earlier. What do you notice here? Patient stated she just used her own albuterol inhaler. So they didn't do a post-bronchodilator, even though it was indicated. I'm a little more wary that they had just used their albuterol inhaler and were still getting horrendous results. Now, I don't know, it just said good effort. Every technician documents a little differently. Your protocol may vary at your institution, so you don't always have all the answers. This looks like a pretty significant obstructive disease. And once again, the flow volume loop tells the story, the volume time scalar tells the story, but really the numbers are what definitively allow us to say this absolute value here, less than 70, meets gold criteria. And again, their peak expiratory flow, 20% of what it should be. This is one I did. I'll try to be really specific. They reported something a little unusual pre-test. They complained of mid-sternal pain with occasional mid-scapular pain posteriorly, and they said they occasionally take ibuprofen, PRN, and pain resolves. So it was ruled out non-cardiac before they came to me. So what you have here is you have normal FEV1, FVC values individually. Their actual value is not quite 80. It's on the cusp, but it certainly is not, below 70. So this is a fairly normal PFT. What's a little abnormal is you see their peak expiratory flow is about half of what it should be, and the shape of their flow volume loop is a little sketchy, no pun intended, literally and figuratively sketchy. But they did have a really nice plateau, and I do recall they gave a good effort. And at the time, that was really about all we could expect for this patient. They didn't feel so great when they took a deep breath. I mean, what else can you do? So they went ahead and just ruled out obstructive disease, follow up in 6 months. And you see that on occasion. Last real big report we'll do, and then we'll come in for a landing. Again, they're all slightly different. You've got predicted value, you've got your observed value. Percent predicted is the most important column for FVC and FEV1 individually, but your absolute value for FEV1% is certainly the most important for ruling in or out obstructive disease. And here, it's fairly normal. Now, if I get to lung volumes, you can also see 90% predicted for total lung capacity. And the only thing really low here would be your expiratory reserve volume and your FRC. But you have some patients who just have really good abdominal musculature and great effort, and they just squeeze out as much air as possible. So most everything looks normal, except a couple of values are askew. You can see no diffusion impairment, 92% of predicted. Hey, that's an A on an exam last time I checked. They did not do a post-bronchodilator or any other studies on this patient. This is their flow volume loop. There's a little bit of a break here. I won't say a break in the loop, but the patient began to expire forcefully, and it's almost like they either stopped for a split second or you had a little smidgen of obstructed air that was able to escape. But again, based on the values, nothing to really write home about. Here's just another page comparing, and I always like this if you have this ability to look at what they did, 1 year prior, and they had their follow-up visit, 6-9 months, and just see what changes you see. As expected, our forced vital capacity slightly decreased. I mean, as you age, your lung tissue does deteriorate past a certain age, but there was nothing extremely significant. You can see percent difference was noted. This is different than percent improvement or not on a post-bronchodilator. This is just basically comparing 2 sessions. In this case, looks like about 6 months apart. All right, last one here, not a PFT, just something to consider. So in closing, if you think you might be remotely interested in becoming officially credentialed as a pulmonary functions technologist, the National Board for Respiratory Care does offer a 2-level exam all in one. You can see the eligibility criteria listed to the right, and I would feel confident that most all of you on the webinar today would likely already be eligible. If you work regularly in a PFT lab, I would encourage you to consider taking this exam. And some employers will pay for the exam, and on occasion, depending on your facility, you might see an increase in pay or at least opportunity with the extra credential. And I appreciate your attention. Love to take any questions you have.